Geriatric assessments are key to personalized cancer treatment plans, but most older adults still aren't getting them.
In the field of geriatric oncology, the real non-adherence really lies with us, the clinicians, and the health systems.
Welcome back to Cancer Buzz, where we share the latest in oncology with you each week. I'm your host, Summer Johnson. For 15 years, ACCC has honored cancer programs that advance access, quality, and value in cancer care delivery with the Innovator Awards, presented at the ACCC National Oncology Conference, where oncology leaders gather to learn from one another.
Precision oncology is not just about tailoring treatment of the cancer to its molecular characteristics, but really tailoring the treatment plan to the needs of our patients and families.
That's Dr. Ramy Sedhom, a medical oncologist and division chief at Penn Medicine Princeton Health. He's being honored as one of this year's ACCC Innovator Award winners for building a scalable geriatric oncology program.
Let's frame the challenge for the care of older adults. We often talk about patients or hear these conversations in the hallway about someone being non-adherent, missed doses, skipping follow-ups. But in the field of geriatric oncology, the real non-adherence really lies with us, the clinicians, and the health systems. So despite evidence-based guidelines recommending geriatric assessments, really since 2018, the majority of older adults with cancer still don't receive them. This isn't a knowledge problem, it's a change problem. So our call to action was really, how can we get what we know to be standard of care implemented into our clinics?
What are some of the ways that you've seen geriatric assessments benefit patients?
So the stories that, for example, come to mind are someone like Mrs. Smith, whose name I'm changing for the purpose of anonymity, who had an early lung cancer, did not want treatment at the time. And, fast forward 1 year, she ends up having incurable disease. She had basically two things that were most important to her when I had first met her in the medical oncology clinic. Number one is she wanted treatment of her cancer. And number two, she never wanted to actually come to clinic. So as you might imagine, that sets us in a very hard bind. How do you treat someone for cancer while minimizing them coming to the actual oncology clinic? So, in learning and doing the geriatric assessment, we learned that she had excellent social support. Her son, for example, lived at home with her. She did not have any psychosocial issues, but she actually had a lot of physical impairments where going to and from the clinic was very challenging for her. So the care plan that we were actually able to devise is to treat her with immunotherapy as a single agent, as opposed to combination chemoimmunotherapy, because the latter had a higher likelihood of toxicity and needing to come in for supportive care visits or hospitalizations. And it actually allowed us to leverage another innovation we have at Penn, which is the ability to treat people at home. So what ended up happening with Mrs. Smith is she ended up getting home immunotherapy for about 9 months before her disease eventually progressed. And in honoring her preferences to minimize healthcare time and what was most important to her, we actually had a seamless transition to hospice. And, I cared for her using telemedicine and labs at home. So just a salient example of how understanding our patients and tailoring, their care could be really meaningful. And I think to me, this is a node that precision oncology is not just about tailoring treatment of the cancer to its molecular characteristics, but really tailoring the treatment plan to the needs of our patients and families.
As an Innovator Award winner, you'll be presenting at ACCC's National Oncology Conference this October in Denver. Can you talk about what you're hoping to share with fellow oncology leaders at the conference?
So in our session, I think we're going to share the principles of change. So what did we actually do to make sure that geriatric assessments happened in the clinic? So a lot of this is, what's the infrastructure behind it? What are the care pathways? What did we build into the EMR? What were some of the challenges? What data did we collect? Why did we choose, for example, to use the practical geriatric assessment as opposed to some other tool? What are the outcomes data that we were able to collect? What were some of the formal solutions like EMR flow sheets, order sets, dot phrases, use of dashboards? And really what brought this all together to make it a sustainable program? The other aspect, which we really hope will come through the presentation, is really the equity imperative. So again, older adults really face layered inequities in access to cancer care and in supportive care access once they do start treatment. So I think the central theme is that embedded geriatric assessment isn't really a luxury, it's really justice, and it's really quality care. So we really must default to doing these things, to investing in understanding our patients as persons, and most importantly, to align the care they receive with what's appropriate and what's aligned with their values.
Thank you, Dr. Sedhom. Want to learn more about how Penn Medicine Princeton Health made geriatric assessments the standard of care at their center, or how 5 other Innovator Award winners created groundbreaking programs? The show notes have a link to sign up for the 2025 National Oncology Conference. That's October 15th through 17th in Denver. Thank you for listening. From the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.